Assalamu alaikum. Good morning to everyone. Today I will be talking on sinus and fistula. You know, every day we are losing our closer and dearer ones. We lost our Dr. Samirul Bhai, one of our colleague from orthopedics in Chattogram Medical College. All of you prayed for him, I know. Once again, I will request all of you, those who are viewers and everyone, please, for his departed soul. So today I will be talking on a very common topic, sinus and fistula. I had a very long list of requests, particularly from the third year, to talk on sinus and fistula. So on that ground, I will be talking sinus fistula as well as some points on the preauricular sinus, pilonidal sinus and perianal fistula, because in our day-to-day practice we are facing a lot of cases of this common problem of surgery, and my focus will be on particularly the very basic things of this terminology, which are very much related to the graduate and some points on postgraduate level, because these are a very huge topic. So to begin with the sinus, and the first question to be asked, what is the sinus? Sinus actually means hollow. Sinus means hollow or a bay. So sinus means hollow or a bay. So how can you define the sinus? It is a one-end blind tract extending from an epithelium into the deeper surface. So how can you define a sinus? Sinus is one-end blind tract extending from an epithelial surface into the deeper tissue. That's how we can define the sinus. And this lining epithelium or lining of the sinus is unhealthy granulation tissue, and sometimes it may epithelialize. So once there is epithelialization of the sinus, then it will not heal anymore. Just I can show you the picture how it looks like. You see, this is a sinus. This is nothing but the epithelium. This is the deeper tissue. So as I told you, it is a one-end blind tract. You see, this is a tract. This is a sinus tract. One end is blind and the opening is on the epithelium. So it is a one-end blind tract extending from an epithelial surface into the deeper tissue. So as I told you, the lining of the sinus is unhealthy granulation tissue. Sometimes it may be epithelialized. Once this is epithelialized, it will not heal. So sinus is one-end blind tract. And the other one is the fistula. I am telling you some basic things of this terminology. And what is the fistula? Actually, again, the sinus, just few types are there. Sinus may be congenital, may be acquired, you know. If I tell you some example of the congenital sinus, because these are asked in the exam. So the congenital sinus may be the preauricular sinus. You know, there is a sinus inborn just in front of the tragus. And some of the sinuses are acquired. Acquired sinus, you know, the osteomyelitis is one of the common, then tuberculosis, pilonidal sinus, and pilonidal sinus and preauricular sinus I will discuss in details. So these are the example of these sinuses. Congenital sinus is the preauricular sinus, and the acquired sinuses are osteomyelitis, tuberculosis, and pilonidal sinus. And if we define the fistula, because these are the very common topic that is asked frequently in the exam, particularly in the graduate level. So what does the fistula mean? Fistula means is a flap or the pipe or a tube. So fistula means as a tube which has a two opening. So how can you define the fistula? Fistula is an open tract, open, both ends are open, communicating two epithelial surface or between two endothelial surface. So fistula is an open tract. The sinus was one-end blind tract, but the fistula is an open tract communicating two epithelial surface or two endothelial surface. That is the fistula. I can show you the fistula picture, then you can understand very easily. You see, this is the fistula. You see, this is one of the epithelial surface. This one is the another epithelial surface. So it has got communication between the two epithelial surface. One epithelial surface or endothelial surface, another epithelial surface or endothelial surface, and it is both. This is the tract and both ends are open. So the fistula may be defined as an open tract extending from one epithelial surface to the other, or from one endothelial surface to the others. So this is the fistula. As like as that of the sinus, the lining is also unhealthy granulation tissue, and sometimes it is epithelialized with the true epithelium. So once it is epithelialized, it will not heal anymore. So this is a basic, the fistula, how it looks like. Once again, there are some types of the fistula as well, like as that of the sinus. So how can you classify the fistula? Fistula you can classify as a congenital. You know, so many congenital fistulas are there. What are those? One of the common is the branchial fistula. I will show you the picture. The branchial fistula, tracheoesophageal fistula, AB fistula. AB means arteriovenous fistula, and the umbilical fistula. These are the few congenital fistula, because these are asked in the exam. Give example of congenital fistula. I am telling you again. The branchial fistula, one of the congenital fistula, tracheoesophageal fistula, AB fistula. AB means arteriovenous fistula, and the umbilical fistula through the umbilicus. These are the congenital fistula. There are a lot of acquired fistulas are there. Acquired fistula may be due to trauma, may be due to surgery. So the traumatic or surgery fistula, sometimes intestinal fistula, postoperative. I will show you the picture. Intestinal fistula is acquired fistula, biliary fistula, acquired fistula, pancreatic fistula, all are gynecological fistula, BBF, RBF, all these are the acquired fistula. And these are all due to trauma or even surgery. There are some fistulas which are due to the inflammatory condition. There are some inflammatory condition like the intestinal actinomycosis, tuberculosis, or Crohn's disease. So the tuberculosis is very common in this part of the world. Crohn's disease is not so common. So these two are the actinomycosis. This may give rise to the inflammatory fistula or enterocutaneous fistula like this. And some of the fistulas are due to the malignancy, neglected malignancy or advanced malignancy, like rectovesical fistula, the communication between the rectum and the what is called the bladder, urinary bladder, or sometimes you may see the vesicocutaneous fistula due to the advanced malignancy of the urinary bladder. So these are the few acquired fistula. So the fistula may be congenital, may be acquired. Acquired case may be due to trauma, may be surgery, may be inflammatory condition, and sometimes malignancy. So the external opening of the fistula may be single, may be multiple. In the fistula's communication also may be single, and sometimes it is multiple. And if I show you some of the pictures of the fistula, you can easily guess how it looks like. This is actually the sinus, the preauricular sinus. You see the preauricular sinus, complicated abscess. These are abscess and the scar around the fistula. And there are some other sinuses also. These are sinus from the stomatitis. You see, stomatitis. This is the sinus of the tuberculosis, typical on the neck. Multiple sinus in the neck. You see, this is the pilonidal sinus. Is a natal cleft. The pilonidal sinus, multiple opening. Another pilonidal sinus. So these are the sinuses. Again, once you see the stomatitis sinus is actinomycosis sinus from the actinomycosis, preauricular sinus. And if I show you some of the fistulas, as I told you earlier, these are the congenital fistula. The branchial fistula is a typical branchial fistula, is in the lower part of the neck, and is actually lower part of the neck and in the anterior border of the sternocleidomastoid. It is actually the failure of the second with the fifth branchial arch. If you are in a postgraduate examinee, then you may face these sorts of short case. You see, this is umbilical fistula, the fecal matter you see. This is actually case of the AB fistula, arteriovenous fistula, maybe congenital, maybe therapeutic for the dialysis patient. You see the AB fistula, arteriovenous fistula. And these are all the shortcuts. This is a congenital one. You see there are a few types of the tracheoesophageal fistula. I am not going in details. You see one ends blind, it is the commonest, distal one. This is the commonest one. You see this is actually the trachea, and this is the esophagus. So the tracheoesophageal fistula distal is the open, and proximal end is blind. This is not very common. Both ends are blind. You see both ends are open after joining, and proximal end opens into the trachea, the distal end blind, and both ends are open separately. So these are the few examples of the congenital fistulas. If you see some acquired fistula, you see the fecal fistula postoperative. You can see the vesicocutaneous fistula is also the postoperative, and you can see the biliary fistula. You see the bile. These are due to the postoperative cases. So these are the few examples of the fistula. You have to diagnose the case from the nature of the content, site of the location. So fistula may be congenital, may be acquired, as I told you earlier. It may be external, may be internal. If you see the external opening from outside, that is the external fistula. And sometimes you cannot see the fistula's communication because it is within the body cavity. So these are called the internal fistula. So the fistula may be external, may be internal. As I told you, I shown all the pictures are almost external fistula except the tracheoesophageal fistula. So the tracheoesophageal fistula are the internal fistula, and the other external fistula, as I told you, the perianal fistula, branchial fistula, thyroglossal fistula, and the intercutaneous fistula, biliary, all are fistula, umbilical fistula, all are the external fistula. And can you give the example of the internal fistula? As I told you, tracheoesophageal fistula is one of the internal fistula, and choledochoduodenal fistula. Once we go for the lap chole, sometimes we've encountered this. The gallbladder is communicated with the duodenum. It is the internal fistula. Sometimes a colovesical fistula. Colovesical fistula may be due to the malignancy of the advanced colon cancer, and rectovaginal fistula, gastrocolic fistula. Even the gastrojejunostomy is also a fistula. So fistula that cannot be seen from outside, that is internal fistula. These are the few examples. And the fistula we can see from outside, that is external fistula. Most of the fistulas are external fistulas, either with a single or multiple opening. So what are the clinical features of fistula? I am telling you the common features of the sinus and fistula, or clinical feature as a whole. The commonest problem is the discharge. Discharge of different type, different nature, different character, of different odor. I will tell you in details. So the common problem of the sinus or fistula is the discharge. Sometimes you may find the sprouting granulation tissue around the opening of the fistula or the sinus. And if you find the granulation tissue, exuberant granulation tissue in the opening of the sinus or fistula, that may indicate some sorts of foreign body inside, like osteomyelitis or the foreign body. There may be surrounding induration around the fistula opening. You may find regional lymphadenopathy or lump, particularly if it is due to tuberculosis or inflammatory one. So it may find the regional lymphadenopathy, so enlarged lymph node in and around the fistula. Sometimes if you press the area around the sinus, if you press surrounding area around the sinus, the characteristic content of this sinus may comes out. So that is one of the diagnostic feature. And sometimes if it is due to the osteomyelitis, you may see the induration of the surrounding bone or beneath bone over the sinus. So these are the few what is so-called the clinical feature of the sinus. If I repeat, is discharge is a very common problem. You may see the exuberant granulation tissue. There may be surrounding induration around the opening. You may find either regional lymph node or not, and if you press, there is a characteristic content comes out from the sinus, and sometimes you may get the indurated bone if it is due to the osteomyelitis. And one of the $1 million question is asked in the exam is particularly for the junior and also for the senior to be kept in mind. Once there is a sinus or fistula, when it does not heal, what are the causes? So that means what are the causes of persistence of a sinus or fistula? Keno sinus or fistula heal hoy na? সাধারণত এটা থার্ড ইয়ার বা ফিফথ ইয়ারকে জিজ্ঞেস করা হয়, ভেরি অল্টারনেট স্টুডেন্টকে জিজ্ঞেস করা হবে। সো হোয়াট আর দ্য কজেস অফ দি persistence of a sinus or fistula? One of the common cause is foreign body. If there is a foreign body in the sinus or fistula, like the osteomyelitis, a sequestrum or the suture material, it does not heal. But two, if there is a non-dependent drainage, suppose abscess is in the upper part of the breast, you have drain, in lower part of the breast you have incision in the upper part, so there is a persistent cavity, it is not drained properly. If there is a abscess drain, if not drained properly, it may give rise to the sinus or fistula. Sometimes there is a persistent obstruction. If there is a distal colonic obstruction or a urinary obstruction, but there is a proximal fistula, so it will not heal. So to heal a fistula, there must be distal clearance. Number 4 is the lack of rest. If some parts of the body have no any rest, it will not heal anymore. And if the fistula or sinus tract is lined by epithelium or endothelium, it will not heal. If there is a dense fibrosis of the tract, if you feel the chronic perianal fistula which are cord-like tract, it will not heal of its own. And sometimes you know that some of the infection or some of the fistulas are called the specific disease, like tuberculosis, actinomycosis, Crohn's disease, or due to malignancy, radiation, like that. So it will not heal until you are treating the primary cause, and sometimes malignancy. So if I summarize, what are the causes of the persistence of a fistula? Presence of foreign body in the sinus or fistula, if there is a non-dependent drainage, if there is a distal obstruction of the fistula, I'm sorry. And lack of rest. If there is the affected parties have no rest. If the sinus or the fistula is lined by epithelium, it will not heal. There is a dense fibrosis. If the sinus or due to the particular disease, specific disease like TB, it will not heal. And if there is some malignancy. So these are the few causes why the fistula or sinus do not heal. Now another question is characteristics of ditchers. There are some characteristic ditchers of a particular sinus or fistula. If you can memorize, particularly for the clinician, it is very important. You can at least guess what is the causes of the sinus or fistula from the nature of for the ditchers. Like if you find the discharge is purulent, purulent means pus misrito, pus. So if you see the purulent, it usually the bacterial infection indicates. If you see the caseous or serous ditchers, it is actually the tuberculosis, but it's not confirmatory. If you see the sulfur granules from the ditchers, it is actually the actinomycosis. Some you see the mucus ditchers, it is actually the bronchial fistula. And if you see the saliva from the fistula or sinus pore, it is a parotid fistula. And if you see the feces, fecal fistula. If you see the urine, urinary fistula. If you see the bile, is a biliary fistula. And so these are the, and if you see the bone or dead piece of bone pouring out from the coming out from the sinus tract, it is actually the maybe the osteomyelitis. So from the nature of the ditchers, you may guess idea about the what sinus or fistula. If I tell you purulent indicates the bacterial, caseous or serous discharge is tuberculous. If there is sulfur granule, it is actinomycosis. If there is mucus, it is a bronchial fistula. If you see the parotid, it is saliva is coming out. If the feces is fecal fistula, bile, biliary fistula, bone, osteomyelitis, and the urine is the urinary fistula. So these are the few points of ditchers, how you can guess about the sinus or fistula. Sometimes there is a characteristic odor, gondo dekhe onek shomoy amra idea pete pari. If the sinus is due to the gas gangrene, it is a sweet odor, mishti ekta gondo thakbe, it is so called the decayed apple like মানে আপেল পচে গেলে যেরকম একটা গন্ধ করে ওইরকম একটা গন্ধ গ্যাস গ্যাংগ্রিনে পাওয়া যায়। এর আরো অনেকগুলো ফিচার আছে। সো ইফ ইউ ফাইন্ড দ্য সাইনাস from the gas gangrene, it is a sweet at odor and they delayed or decayed the apple like. If you see the odorless E. coli sinus is usually odorless, and you see the anaerobic infection, it is actually the very foul smelling ditchers. And if you see the fecal odor, is a fecal fistula. If you see the urinary odor, urinary fistula. And sometimes you see the nature of the ditchers. As I told you earlier, if you see the pus, it is streptococcus, and sometimes it is blood stain. And if you see the yellowish creamy, then it is staphylococcus. And if you see the greenish, sorry, greenish, then it is pseudomonas. And if it is liver abscess, it is anchovisius. Why I am telling you this things, because some of the examiner is used to ask this question: what are the nature of the ditchers, what are the color of the ditchers, or what are the odor. So you have to keep in mind. Sorry. Now, once you encounter a sinus or fistula, then what are the history to be taken? One is how long the fistula or sinus is. Is it since birth or not? If the sinus or fistula is since birth, it is a congenital one. So it is a preauricular sinus or branchial fistula sometimes. It is a congenital one. Sometimes you have to ask the patient whether any fever, swelling, pain, or any abscess over the ditchers. If patient gives the history of fever, pain, swelling, sorry, if the patient gives the history of fever, swelling, pain prior to the development of the sinus, it may be due to the osteomyelitis. You can guess. If the dead piece of bone comes out through the fistula opening, it is due to the osteomyelitis. If you enlarged lymph node in the sinus, you can give an idea about the tuberculosis, or sometimes a patient may give rise to the pain. Sometimes the swelling is enlarged, gives rise to the abscess, and it's burst. That is cholesterol abscess burst, and it may be due to the tuberculosis. In perianal fistula, patient usually gives history of the perianal pain, then swelling, development of the abscess, either it burst or drain, then it gives the fistula in ano. And sometimes the fistula in ano develop after the surgery. So these are the history, some of the point that gives you clue about the diagnosis of the sinus and fistula. So how to examine? Again, inspection and palpation. The inspection, what you will see, number one is the number of opening. You will see how many numbers are there. So most of the cases, sinus or fistula has a single opening externally. Internally also the same. So the most of the sinus or fistula has a single opening, number one. But sometimes you may find the multiple opening. Sinus or fistula has a multiple opening too. So what are the condition? Question to be asked. What are the condition you may find the multiple external opening? Number one is the watering can perineum. I will show you the picture. You know, the watering can perineum is actually nothing but the urethrocatenaceous fistula is a devastating condition, very difficult to treat, you know. And if the some fistula or sinus is due to the chronic disease like ulcerative colitis, Crohn's disease, tuberculosis, actinomycosis, and sometimes the malignancy, these are all gives rise to the multiple external fistulas or sinus. So the question to be asked, what are the causes of multiple opening? Or if you find a multiple opening, what are the things you will be considered? One is the watering can perineum, that is urethrocatenaceous fistula, and some chronic disease like Crohn's disease, ulcerative colitis, tuberculosis, actinomycosis, malignancy. So if you find the multiple opening, you have to consider these sorts of diagnosis. So somebody please give a comment whether I am audible or visible, please. And you see the multiple opening is a watering can perineum. You see how many openings are there. Is again watering can. How can you see the multiple opening? And the watering can perineum is the probe. So these are the watering can perineum with the multiple opening externally. So if you find this source of multiple opening, it is almost diagnostic of the what is called the watering can perineum. And number two, what is the position of the opening? Number one, I told you during inspection is the number of opening. It may be single, may be multiple. Okay. And now the position of the opening. It is very important. From the position of the external opening, you can easily diagnose what type of sinus or fistula it is. Number one, if you find the opening in the preauricular region, it is nothing but the preauricular sinus. Sometimes the fistulas, parotid fistula may be there, but very rare. So if you find an opening in the preauricular area, that is nothing but the preauricular sinus. If you find an opening in the lower part, it is actually the bronchial fistula. And if you see the opening in the neck left, back, lower part, just behind the anus, that is a pyloric sinus. And if you find sometimes the multiple or single opening in the side of the neck on either side or one side, actually the tuberculosis. So from the site of the opening, you can diagnose easily what is the type of sinus or fistula, the preauricular sinus, bronchial fistula. You may find the tuberculosis sinus due to the tuberculosis. You may lower back the pilonidal sinus, and sometimes you may find a single opening in the mentis. It is a median mental fistula due to the osteomyelitis of the mandible. So these are the few typical site of sinus or fistula. Sometimes you may find the exuberant granulation tissue into the opening of the sinus or fistula. As I told you earlier, if you find the exuberant granulation tissue in the opening of the sinus and fistula, it usually indicates the foreign body inside, either osteomyelitis or dead piece of bone, sequestrum, or sometimes the foreign body like the suture material we usually encountered after lap chole or laparoscopic surgery, the umbilical port where we put a suture material inside in the linea. Sometimes it does not heal. So once you remove the suture material, and then it is healed. So this is one of the example of the foreign body. So what are the discharges? As I told you earlier, from the osteomyelitis pus comes out from the TP serous or the granular or the caseous, and sometimes actinomyces sulfur granule. So if I show you some of the picture once again for the typical site, then you can easily memorize. You see the typical site of a preauricular sinus. You see the typical bronchial fistula, anterior part of the sternocleidomastoid in the lower third of the neck, median mental fistula with the exuberant granulation tissue, as I told you, due to the osteomyelitis of the mandible. You see the tuberculous ulcer, tuberculous sinus, multiple, and this is actually the pilonidal sinus. It is a single midline opening and two lateral opening. This is the secondary extension. This is a primary. So these are the few picture of the multiple types of the sinus and fistula. And next, in fistula, there are some characteristic point. If you see the feces is coming out, it's a fecal fistula. If you see the bile is coming out, is a biliary fistula. If you see the urine is coming out, this is urinary fistula. So from the content, you may get the idea what type of fistula it is. And the surrounding skin around the opening. If you see there is a scar in and around the what is called the primary opening of the fistula, that will indicate something, maybe due to the chronic osteomyelitis or the tuberculosis. Sometimes a very common problem in the female breast, particularly granulomatous mastitis, and you will see the abscess and sinus here and there and on and off. So you will see the some scar in around the sinus or fistula. So if you see scar in and around the sinus or fistula, then you may guess it is due to the tuberculosis, maybe osteomyelitis, or maybe granulomatous mastitis. Sometimes you may see the pigmentation or the dermatitis around the fistula or sinus opening. That indicates the chronic discharge of the or chronic disease like actinomycosis or Crohn's disease. Okay, so now the palpation of the sinus or fistula. If a sinus is from the osteomyelitis, once you palpate, you may find it tender, and sometimes the sinus or fistula wall is palpable, thick cord, particularly in the perianal fistula. If you do the PR, you can identify the tract of the fistula in ano. So that indicates the chronicity. Number 3, and mobility. Usually the fistula or sinus, it does not move. Very infrequently it moves. So sometimes the osteomyelitis is communicated with the bone. It does not move anymore. And you can feel the lymph node in and around the sinus. In every case, you have to examine the regional lymph node. So if you find the regional lymph node is enlarged, it may be due to the infective, either acute or the chronic tuberculosis. And sometimes you have to examine the sinus or fistula with the probe. But for the probe examination, it is very painful. It is not wise to examine without any anesthesia. If you want to examine with the probe, it has to be done under general anesthesia. So it has to be kept in mind. And how to understand from the probing, I will show you the picture how to probe. We can guess idea about the depth of the sinus or fistula, or are there any foreign body inside like bone or any other things, and what is the direction of the fistula. So from the probing for the postgraduate, how can we guess idea from the probing? From the probing we can get idea the depth of the fistula or sinus, direction of the fistula or sinus, any foreign body inside like bone piece, or we may get idea about whether it is a sinus or fistula, if there is a communication with the other cavity, and that it is the fistula, neither sinus. So if I you see probing, metallic probe in the fistula in this is also probe, and it is a antegrade probing. Sometimes we do the antegrade probing. You see is best antegrade probing. You can probe the sinus or fistula from inside. Okay, and this is the preauricular sinus. As I told you, you can see how can you probe is a what are the things you can use for the probe. You see the IV cannula. IV cannula can be used with the for the probing of the preauricular sinus, and you see the metal in perineum. So this is how we can do the probing, or we can examine the probing, because from the probing we can get idea the depth, direction, any communication or any foreign body. So these are the palpation, and of course you have to examine the draining lymph node of a sinus or fistula. So for the particular some fistula, you have to examine some particular things. Suppose if you find the fistula in or the sinus, you have to do the parectal examination, because the pilonidal sinus is one of the differential diagnoses, the fistula, anal fistula, so you have to exclude. Number one, if you find the tuberculosis, if you guess it is tuberculosis, so you have to examine other lymph node, and chest you have to examine. And if you see in the mandible, sinus is in the mandible, to look for the oral cavity, particularly for the teeth or any other inciting factor causing the osteomyelitis of the mandible. What are the investigation to be done for the sinus or fistula? Any infective ulcer or wound or the sinus or fistula, the first investigation is the pus culture. Pus for culture and sensitivity, and sometimes you may do the what is called the FB stain, bacilli, if you think it is a tuberculous, and sometimes you may do the gene expert from the content. If the content is profuse amount, you can do the cytology for malignant cell. So the first investigation of a sinus or fistula is culture and sensitivity. You may do the FB stain or the gene expert too. And the next investigation, where it is indicated, is the X-ray of the affected part. If you find it is due to the osteomyelitis in a limb, the next investigation will be the X-ray on all views, whatever the possible. In my X-ray classes, I told you about the X-ray. Then fistulogram or sinus. Actually, it is an obsolete one, no more practiced. But the CT fistulogram or CT sinogram is helpful, and most of the important investigation for the sinus or fistula nowadays is the MRI. So MRI is the standard for the sinus or fistula, but there are some disadvantages also, and ultimately you have to do the biopsy either by excision biopsy or from the exuberant granulation tissue. You take the tissue, then send it for biopsy, you can see the cause. So what are the investigations? Sensitivity, FB stain and the gene expert, X-ray part, fistulogram or sinogram sometimes helpful. C2 sinogram you can do, and MRI is the gold standard, and ultimate court of appeal is the biopsy. So these are the few investigation, and for any type of sinus or fistula, treatment is excision and biopsy, and of course you have to treat the primary cause. If it is due to the tuberculosis, you have to treat accordingly until or unless you are treating the tuberculosis, it will recur or it will not heal anymore. And of course, after sinus or fistula surgery, the whole care, you have to take care of the post-operative wound. And if I show you some of the picture of X-ray of the osteomyelitis, you see how it looks like. The osteomyelitis, sequestrum, dead bone, and sinus, and how it looks like in the X-ray. You see, very typical of osteomyelitis. Another X-ray of osteomyelitis. So, the sinus cavity. You see the sinus cavity. The sequestrums are there. You may be asked in the exam, what is sequestrum? Sequestrum is nothing but the dead piece of bone within the living bone. This is the sequestrum. Okay, so these are the sequestrum. Now we'll tell you these are all in about the sinus or fistula in common. Now I will tell you something on sinus, because it's a common problem and it is given in the exam as a short case, very simple short case. So you may face in the exam as a short case. What are the common question to be asked from the preauricular sinus? I told you earlier, preauricular sinus is a congenital sinus. Why it happens? It is due to the failure of fusion of the 6 cartilages of the 6 tubercles of the external ear. So if there is any fusion of the 6 tubercles of the pinna, that may gives rise to the called the preauricular sinus. And this preauricular sinus may be single opening, very rarely multiple opening. Okay, and it may be unilateral or sometimes it is bilateral, but most of the cases is unilateral. And where the opening is there, it is just root of the tragus or root of the helix or in over the tragus. I will show you the picture, then you can easily see. You can see here is a preauricular sinus, you see, and the direction of the sinus is actually the backwards and slightly upwards, and there is no communication with the external ear. You see, you cannot see any communication with the external auditory meatus. Sometimes the opening is blocked, it may gives rise to the abscess, and rarely there is a multiple opening also. And sometimes you may find this scarring in and around the opening, that indicates the chronicity. So what is the problem? The problem one is the cosmetic problem, recurrent pain and discharge, and sometimes the recurrent swelling appears and disappears. So swelling appear and disappear, pain and discharge, and the cosmetic problem. And how to differentiate? If I show you the picture, you can see the preauricular sinus just over the tragus opening is abscess develop. Abscess how can looks like a pus. You see the chronic preauricular sinus with the scar, the multiple ulcer, neglected multiple ulcer, and you see the single ulcer. So you may find these sorts of complication like this. And what is the differential diagnosis? Is a very common. Use the preauricular sinus. It looks like a sebaceous cyst. Sebaceous cyst. So one of the differential diagnosis of the preauricular sinus is the sebaceous cyst. You have to keep in mind. But once you are doing the surgery is excision biopsy. As I told you, the excision biopsy is the answer. But one question is asked in the exam: what is the of the surgery? As I can show you the picture, you see this is the incision. Sorry for the interruption, there's some technical problem. So please, those who are new with this presentation, please continue with the previous one. যারা এখন আমার সাথে জয়েন করেছেন, আমি আশা করব তারা আগের ভিডিওর সাথে কন্টিনিউশন হিসেবে এটা দেখবেন। সো এতক্ষণ আমরা সাইনাস, ফিস্টুলা এবং প্রিঅরিকুলার সাইনাস সম্পর্কে আলাপ করেছি। এখন আমি আর দুটা বিষয় নিয়ে আলাপ করব, সেগুলো হলো যে one is the pilonidal sinus and the other one is the fistula in a very common topic. আমি বেশি ছবি দেখানোর কারণে ভিডিওটা লাইভ ভিডিও